hearing from everybody.
Yeah.
So today we're going to talk a little bit about lateral elbow pain and how it can be just a little bit on the tricky side.
Yes.
So I'm thinking of a couple of clients that I've had recently that have all come in with, holding the side of their arm and telling me that
Mm,
that's where they hurt. Excuse me.
that's
And
okay. I'm just
usually,
looking down.
and usually by the time they get to me, that's pretty chronic. So they've had it for a good long time, and they're having difficulty doing all kinds of things. But the biggest thing that really brings them into the office finally, excuse me just a minute, go ahead and talk,
That's
Erica.
okay. No, is lateral elbow pain. So we've gotten, when I was when I was doing the Canva graphic, I'm like, lateral elbow pain. I've had it myself, and of course, typically, oh, it'll get better. It'll get better. It'll get better. And I'm doing my radial nerve glides in the shower. This is years ago, and and I often find that when you really palpate those tendons, it's really, really, really sore. And I don't necessarily think doing friction massage on those extensor tendons is like really helpful, to be honest. I mean, you may need blood flow, but for me, I tend to have a sensitive system. That doesn't really help personally. So, do you want to continue, Susan, or do you want me to
Yeah,
keep going?
yeah, thank you. Sorry, it's a little bit of
Oh, that's
spring
okay.
allergies going on here.
Oh, I know. Crazy.
The interesting thing is what really brings them in to finally see me, or at least the last several people I've had with this issue, is that they can't sleep at night. They're
Ah,
waking up
interesting.
in pain with it hurting in the nighttime, and it's really bugging them and bothering them, or they're waking up in the morning and it's just killing them. And so, which always kind of clues me into, okay, maybe this started, in that tissue area around the extensor brevis muscle or attachment or things like that. But perhaps maybe it has actually, um, become much more of a sensitized nervous system.
Yes.
And I think that's probably why you're talking about doing the deep friction massage right on the brevis can be exquisitely tender, but it also may be that too much input to a system that's now kind of converted over to kind of maybe, even if it's not a central sensitization, at least a peripheral sensitization,
Yes. Yes,
where
for
the
sure.
peripheral nerve has really gotten quite sensitive,
Yes.
through that area. And I think what really ends up starting to happen with people at nighttime is, one, positioning, and number two, what's going on with their neck. And if they're
Yes.
going into neck extension and weird things at nighttime, is that firing off that sensitive, from the, like, is that nerve sensitive all the way up into the cervical area, through the
Hmm.
brachial plexus and up into the cervical plexus.
Hmm.
And really getting people kind of straightened out a little bit at nighttime can be quite helpful, because the other thing people do at night is curl up.
Right. I do
And
that.
we have a natural tendency, everyone does, it's a natural tendency to move into a flexion pattern at nighttime.
Yeah.
That's part of sleeping. And so really trying to help them change that is really quite hard, because no one's going to stop doing this. So I found that splinting, at least for the nighttime piece, splinting has been very, very, very helpful. And you don't need
Splinting the elbow?
the wrist.
Oh, the wrist.
Yeah, because it keeps
Oh,
them from doing this. So I've been playing around with that. That seems to work really, really well for people who are, A, driving a lot, and B,
right.
having problems in bed.
I like
Because
that.
the other time I see with people driving is there's a lot of, reaching down like this to get to the gear shift, even if they're
Hmm.
just going from park to drive. People on the steering wheel, there's a lot of different kinds of things that go on that way.
Hmm.
So the first thing that I do with people is figure out when they're the most symptomatic, and if it's usually positional, like in bed, or driving the car, or something that, it's really hard to wear a splint if you're working. Like, we have
Yeah.
to work on other things with that. But when it's things like nighttime, or lifting and carrying, and, doing those kinds of activities, then a splint can really, really, really help. Because
Yeah.
all it does is keeps the wrist from going into further flexion, so that the nerve can actually, the nerve in the tissue can actually kind of settle down.
Any recommendations on like a short, you know, short
Yep.
one?
Yeah, I just, what I tell people to do is go to, and I'd love to hear any comments anybody has out there too on this. I just have people go over to the drugstore and grab one of those splints that Velcros over,
Oh,
you
yes, yes,
know.
yes.
Yeah, just the cheap, the really inexpensive Dr. Scholl's, whatever, wrist splint.
Oh, I like that.
Yeah, and it doesn't even have to be a cock up splint. Just something to hold them still. So at nighttime, they just aren't going to flex so much. They're still going to,
Yeah.
they may do this, but
Yep.
they'll do it like this. They won't do, you know, the whole position,
Mm-hmm.
with the arm down.
Yep. Yep.
Because that's the test for this, right? For lateral elbow pain is extended elbow, and then we're taking the arm into extension and a little internal rotation, and then
Rotation.
really flexing the
Yes.
wrist to see if that
Yes.
fires up. Well, that's also a radial nerve tension test.
Yes. That's what helped me. I did those in the shower.
Yeah, exactly. So what I'm looking to do is to limit the radial tension, the radial nerve tension
Tension.
in the
Yeah.
system in the short run to get things to settle down.
Mm-hmm.
Because that by the time I see them, they're so flared up
Yeah.
that they can't eat. Nothing's helping.
Yeah.
I mean, they can't do tensionings, they can't do sliders, they can't do gliders. It just hurts. All they want to do is grab it.
Yeah.
And
Yeah.
it just really kills them.
Yeah.
So I found that is like really helpful in the beginning to get people to really settle down.
Yeah, and what kills me is that people they're like, oh, we did this, and all these stretches, and I'm like, and they didn't help, and I was like, well,
Right.
You're really stretching strained tissue. I don't really think that's going to help, So
Right.
it just kills me that people still. I mean, these are the people who are persistent, right? But even with an acute epicondylitis, I wouldn't be stretching those wrist extensors.
You protect, in an acute situation, you're protecting. You still
Yeah,
have to follow the normal physiology of tissue healing. So maybe during the chronicity, it's moved to a chronic state, but they still have a lot of, now you've got structures that maybe are not, you don't, are not, maybe not getting strained anymore, but they've become super sensitive to the movement pattern.
right. Exactly. Exactly.
And
And
so,
no, go ahead, Susan.
yeah, that's okay. So that's why I chose to start. I've played around with taping the wrist. I've played around with taping the lateral epicondyle
Yeah.
into a little bit of, the elbow into a little bit of flexion. Taping the wrist into a little bit of extension. People like that, but it's not a great long-term strategy for somebody
Right.
who's really hurting.
Yeah.
I found that wearing the splint, particularly at nighttime, makes a huge difference for people.
Yeah, that's great advice.
Because if
That's
they can
great
get to
advice.
sleep, they can
Yeah.
start getting better.
Yeah, for sure.
And then so I get them to settle down like that a little bit, and then now we can talk a little. So that's kind of what I do first thing is get them more comfortable immediately, as fast as I can, and then we can start working on the tissues. So now we can start talking about some of the things you were talking about just a minute ago that you had tried on yourself. What are your go-to things? What do you like to do? What do you like to like? How do you like to progress them?
Me? Who else, Erica? um, Personally, I don't do, like in the exam, I'll go in and I'll assess the tissue, but I often, go right to the neck, to be honest. I think there's a lot of, I'll just pick up a patient of mine. She picked up a dumbbell in the gym a while ago, and she literally just developed this acute lateral elbow pain. And she couldn't open a door, your classic, couldn't grip. So I don't give them stretches. I actually give them radial nerve glides to start with. I have them do that. I don't splint, but I will know. I think that's a great idea. I hadn't thought of that, especially with people who have problems sleeping. I tend to, sometimes they'll come in with those, those elbow, those Chopat straps, and I don't think those particularly help.
Sometimes they just feel comfortable.
Exactly. And as long as it doesn't, make them worse, I'll do that. But what initially, I will try some of these mulligan mobilizations, some of the distraction mobilizations, some of the mobilizations for the radial ulnar joint with gripping. Sometimes that help desensitizes the tissue. I've had some success with that. In his book on MWM's Mulligan had, sort of walks you through these. And I've had success with that, primarily with gripping, mostly with gripping. And then I'll progress them through, I'll get on their neck, and I'll assess their neck. And while I'm, either working on their neck, I'll have them go through the radial nerve glide or median nerve glide or any glides when I'm on their neck, either doing a little bit of distraction. Depending on what I find there, I'll have them do the distal movement while I'm working centrally. So I've done that fairly often. Patients of mine have asked me about these eccentric exercises for the wrist, and I give them out. I don't think that some of them are helpful, I know there's a lot of research out there on, depends on, where tendon injury or the state of the tendon when you see them, but they've not hurt. So I will give them out. But in terms of manual work, I do very little tendon, unless it's a significant tendinopathy and the person's not really hurting, but there's significant restriction. I won't generally go in there and start frictioning the tendon at the beginning at
Mm-hmm.
all. I think it really flares them up. I actually work more proximal. I work on the shoulders. I have found that there have been some issues, particularly in the posterior cuff, with people who lack elbow, who lack shoulder external rotation. They'll get up mostly at the medial epicondyle, but the medial condyle, but not so much on the lateral. But they lack some rotational movement, either internal or external, and they'll compensate at the elbow. So what I'll do is I'll go up in the shoulder, I'll assess the tissue and see if there's any sort of, not trigger, not referral pattern, but any sort of restriction that I
Mm-hmm.
could link to the elbow. So I'll have them do some internal, external rotation. I'll assess the elbow. And, at the end of the day, you are doing internal and external when you are mobilizing the radial nerve. So what I've
Mm-hmm.
found is I work more shoulder and neck with nerve glides rather than local, except for those mulligan mobilizations and maybe some eccentrics. That's what
Yeah,
I tend to do.
and I like that because what you're doing is you're actually tensioning the system from another direction.
Yeah.
You're taking them into a little distraction. You're taking them into some side bending, maybe rotation away. As you're kind of getting them to kind of feel and see how that's affecting down the arm, rather than going at the wrist and really working it so hard here, because that seems to trigger off the pain so much more, that you can kind of settle it by kind of like let's try tensioning it from the other end. And we've talked a lot about that in some of our podcasts about, if you've got some lower extremity neural tension things that are going on and you can't really reproduce it by doing tensioning in the leg, but you start winding up the system from above, then you
Mm-hmm.
can actually kind of draw that, you're able to actually kind of start, getting better tension into the neural system down below. So what you're doing is just actually kind of like doing the distractions and the tensioning and the gliders from above to begin
Mm-hmm.
to help settle that sensitivity down further down the arm. I also like your point about the shoulder, because I was going to talk about that. Although, we talked about the knee kind of being the transitional zone for the like hip and foot, like oftentimes you have to go to the knee and see what the knee is doing, because if it's not moving well, that may
Yeah.
be why their hip is kind of flaring up or their foot is is being reactive in certain ways. Well, the elbow is a transitional zone too. However, I think I agree with you. I think that sometimes a lot of the elbow stuff is triggered by a lack of movement, or a movement pattern that's kind of just gotten ingrained, like a dominant movement pattern in the
Mm-hmm.
shoulder.
Yep.
Because of the rotational stuff, if we have a shoulder that doesn't really want to go into internal rotation, then we're going to be over cranking,
Mm-hmm.
maybe perhaps overworking tissues or doing something a little bit different down in the,
Mm-hmm.
the lower part with the pronation supination
Mm-hmm.
to make up for the rotation that may not be occurring up above for
Mm-hmm.
whatever reason. It could be an
Yes.
old injury and it's a compensation pattern that they've developed over time and
Yep.
over the years, or it could be something coming from the neck that has caused an inhibition or a weakness,
Yep.
a local weakness in in some of the shoulder muscles, so they're not working in concert together anymore.
Yep.
And I think that's a super important point, is taking a look at them and like show me, if they're like, show me when you hurt, tell me when you hurt, tell me where it hurts, tell me what activities you're doing, now show me that activity. Let me see you
Yep.
do it. Let me see what's happening here. And sometimes you
Mm-hmm.
may see them like really spread their arms out a whole lot. And, or they may need to, or maybe they're bringing their arms in too much, or maybe they're like dropping over, or maybe they're doing something weird up here. It's just always, I never know what I'm going to see until I see it. And then
Yeah.
it's kind of like, why are you doing that? What's the effort behind that?
Right.
But generally, I think some of the things that happen though with people over time is that they just get into some sort of, they're either trying to work a shoulder and the shoulder isn't, so they just have found a different way to move due to a shoulder problem.
Correct. And I had a patient who, she was a really good golfer. I mean, that wasn't her, she wasn't like a professional athlete, but I will tell you, she played golf all the time. And I've cheated her on and off for different issues. she developed this chronic elbow pain, and turns out she had a lack of external rotation in her shoulder. So whenever
Mm-hmm.
she went through the follow through, she would externally rotate that arm, and it would really be more medial elbow pain. But at the end of the day, it's really important to assess the shoulder. And what I'm also finding, especially well, not just necessarily throwers, but people who just throw with their children, or play catch with their kids,
Mm-hmm.
even when you get them into a weight bearing, let's say a wall push up, that's going to automatically, flare, not flare, that they're going to feel it. So I believe that, not only do you need to do these open chains, you need to do progressive loading on the wall, and you can have them do you can have them just literally have their hands in a closed chain on the wall and walk sideways, walk to the right, to the left, and that
Mm-hmm.
will tension, and then do a squat. So you're going to do your lower extremity nerve glides, but your elbows, your arms are in a position where they're on tension or they're on slack. You can raise them up, you can turn them around, and those are great ways of mobilizing the nerves from below.
Yeah,
It,
I love that, because that's changing it up instead of going above, coming at that nerve from a whole different direction, or that area from a different direction from below, and that even adding in some things like head turns and side
oh yeah,
bendings can really pull that in too. And
that's a good
I
one.
like the weight bearing part, and one of the reasons I like the weight bearing with the open hand is some of the true kind of that it really started in the the brevis muscle, maybe an overworking or overloading, comes from people who are grippers.
Yeah.
So I have seen a number of people in construction that
Mm,
they're gripping, and it's the gripping that gets them. They're not the
yes.
typical like people on the computer all the time, and what they call the competitive trauma overload, that kind of thing.
Yeah.
Sorry, repetitive trauma overload or those types of things. But they're people who grip, and gripping can be very painful for some of these people, that the activity of going back to holding. And so that's where I kind of question so much going straight into eccentrics, because it's not an eccentric movement that's driving them crazy, it's the gripping and beginning to. So I love the weight bearing with the hands out first, because it begins to help them load the
Mm-hmm.
tissue in a non-gripping, non-painful kind of position, which I think is really important. Of course, it pulls in the whole chain and the shoulder, and getting everything on, and like you said, some nerve gliding from a different direction. But then one of the things that I like to do is get them back moving towards a nice gripping type position, where they're starting, so maybe we'll start on something a little bit bigger,
Mm-hmm.
and really having them kind of, and then having them load that and move it around like they would, whatever it is that they're doing, and then work them into smaller and smaller things. And people who lift weights oftentimes run into this too, because they're gripping the weight so hard. Um, and it may be they're gripping the weight hard because it's a little too heavy for them to lift, and it's a compensatory pattern that they've kind of done to like, I can't lift it, so I'm going to grip harder.
Yeah.
And it's like, maybe you should like lower the weight a little bit, so that and let's get the gripping going again, so that you're not over gripping as you're kind of trying to work whatever else it is that you're working.
Yeah.
We have some comments in here.
Oh, I don't see. Oh, here they go. Uh,
So thank you, Annette, for coming in. And we're so glad that you like the podcast and what we're talking about.
oh, oh, there's
Thank you for
Doreen. Hey,
doing
Doreen.
that.
I'm sorry.
And Doreen, welcome.
Hi,
She
Doreen.
says that she just great suggestion so far. If you talked yet of myofascial restrictions in the wrist extensor group that may need to be addressed, also with dry needling,
Doreen's up in
and
Montreal, right? I think Doreen, we're in Montreal.
mhm,
Uh,
to desensitize the system and mobilizing the nerves. Yep, we were just talking about that. 4-point kneel with the hands
Neil.
and wrists in a variety of positions. Yes, exactly, Doreen. And I like, when I was talking about that, I like going flat first, and then I eventually, like what Erica was talking about on the wall, I was going to say I like bringing them into a fist onto the wall, so that they're
Yes.
kind of loading, we're kind of working back into those positions that they need, are on their hands and knees,
Mm-hmm.
can be great. Or if they can't get on their knees, we can do it on a tabletop, and those things work. And yeah, we did talk early about a sensitive system that, we were looking at ways to kind of just really get that system to calm down. And certainly dry needling can be one of them. I don't dry needle, so
Yeah, we
I'll
can't in New
leave that
York.
up to the
Yeah.
experts that do that. But it's a great modality for those people. And then, the myofascial restriction stuff comes into kind of like working that whole upper quarter, and kind of like Erica was talking about the shoulder and some of that as well. Thank you for your comments. Awesome.
I love the hands and knees. Yeah, that's a great
Mm-hmm.
idea, and it's anything to mix it up. And I also think that, we always think about the periphery, and we work centrally, but think about, if you have a movement strategy you've been doing forever, whether you're a professional athlete, a weekend athlete, or just, or not an athlete, or you're really right-handed. Could be that your upper, I'm going to go to the thorax again, as we all know, your upper ribs, it
Mm-hmm.
could be that you loss of control through here. So when you're writing, or when you're sitting, put some balloons under your armpits, or not balloons, balls under your armpits, or towels under your armpits to decompress the upper ribs, and that may help give you more mobility and more control in those open chain movements. And when you're on your hands and knees, you could use the imagery, the scapula floating off the rib cage, and do some really funky movements as well. So I think that you need to sort of keep that in mind, because where the whole plexus is, and I think getting it decongested or decompressed up there is probably not a bad idea either. uh,
Mm-hmm.
and I'm just thinking about the more of the weight bearing stuff, because I really
Yeah.
like that. I'm just thinking out loud here, so
Yeah, no, I think that's great. And the other thing to kind of think about is it really in so that's where we really have that tissue problem that's originating, in that lateral epicondyle or lateral, area. The extensor muscles, or the extensor brevis, I think has been coined the culprit guy, but kind of why that's set up in the first place. But the other thing to consider is that it may really seriously be an issue in the cervical spine. And oftentimes we can get a lot of lateral epicondyle pain, pain coming down, from a C5, C6 restriction,
mm-hmm,
C6, C7 restriction, maybe some spurring or something that's happening around the nerve root that has really got it. And you may not have any neck pain at all. May just
right,
and so we're talking lateral, stenosis there, or lateral spurring maybe, but sometimes we can have a little bit of a central piece that may give it down both arms. So
mm-hmm,
whenever I
mm-hmm,
see it on one side and then they're starting to complain on the other side, that's usually a clue to me that we need to really get up and really kind of
mm-hmm.
figure out what's going on in the neck, and help them get out of compression, and maybe open things up and change it and get some muscle built up around that area as well. Like you were talking about, getting some movement in those upper ribs and like the cervicothoracic area.
Yep.
If you can free that up, I mean, we have clinical prediction rules that say if you can free up the T spine, the cervical spine is really going to react much better. And it's because the
Mm-hmm.
base on it isn't quite so being held so stiff,
Yep. Yep.
and being able to kind of do that. But I think that that's important too. And then so your neuroscreen is really important. And you can do a pretty good neuroscreen without, getting them painful. I mean, you can still test finger extension. You don't have to test it way back here where maybe they can't get up because of the pain, like it hurts too bad to pull it all the way up. But maybe you
Mm-hmm.
can, get in neutral and test, finger extension and, some wrist extension. And again, I
Mm-hmm.
like to go back and test flexion because,
Yes, very important.
oftentimes this comes on, with gripping. And it's
Gripping.
because
Yep.
there's so much tension here to maintain that grip in that position, and to do that work, whatever work they may be gripping around, can be really important as well. So really being able to do your neuroscreening and make sure that you don't have something, uh, um, what do I want to say? Not
Not
sensory change.
sinister.
Yeah, yeah, not irritable, but something that may be more neurological, like power outage going
Yeah.
on. So you've got a very sensitive nerve, but you also have the power outage going on because
Right.
it's
And
it's being compressed somewhere along the chain. Hmm.
correct. And I know David Butler in one of his books, I often give this one out. He talks about doing juggling and doing like twirly hoop, like
Hmm.
figure eights in the air, just throughout your day,
Hmm.
whether it's central or peripheral. Those are just good ways to refresh the homunculus, and refresh and flush the tissues out. So I do give out a lot of his glides,
Hmm.
because I think that just helps from a local perspective, to really flush the tissue. And I'm often wondering, when do we as therapists address if there is a significant tendinopathy in that tendon, whether it's from an overuse or a traumatic injury and just gone wrong or just not treated? when do we actually address that tendon? When do we start to do that? Because, it's clear from the research that tendinopathies exist, but when do
Mm-hmm.
we focus on that as a profession, even though we've maybe think it's cervical spine with a secondary elbow, but we need to address that, don't you think?
Yeah, so my thing is, first I want to get them symptomatically settled down a little bit, so we know what we're dealing with. Because when it's all over the place, it just needs to settle down for me
Yeah.
anyway, and then I can say, okay, do we need to get more into the elbow piece of it? Is it a gripping thing? Is it a full upper quarter thing? Is it a cervical spine thing? Kind of tease that out. And I still think that it's kind of like with any other tendinopathy, we need to think about how we're going to do it. I like the gripping as coming through for those that are having the issue with gripping or have had it around gripping, because I think that's
Mm-hmm.
what you need to address
Mm-hmm.
more than the tendon. But for the people who are having having a real tendinopathy at that brevis tendon,
Yes.
and all the we know that we're not going to change a tendinopathy tendon. We have to build up around it.
Correct.
Is the science behind the eccentric stuff. But
Yes.
my thing is that again, I don't like to drop all the way into a full eccentric, because again, then you're having to grip something too. So I may
Yes.
just start with the hand and with a band on the hand so that the fingers can be extended. So you can have the hand on a table, put the
Yep.
band on it so it's coming down this way, and then they have to work again. Or you can
Got
hold the
it.
band up here and they have to work down against the band. You can do a number of different things to begin to address
Mm-hmm.
loading of that tendon in an open position and then work into a closed position.
Mm-hmm.
In my opinion, my humble opinion, I think people jump to the grip and eccentric work way too soon,
I agree.
because you've got two things going on at once.
Yep.
And I
I
would like
agree.
to see them work open handed more and then work into the grip, or start with working for, work, maybe if you're going to start with the grip, work with the grip and get it going better, and then start adding the movement. So you can
Yes.
start either way, open handed with moving the wrist, or starting with a grip and progressing the grip and then eventually adding the wrist.
Yeah. Yeah.
So
I agree.
I don't think
So
there's never been anything like saying this is better than this or this is better than this.
right.
But we do need to load the tendon eventually
Yes.
to build
Yes.
up enough stuff around the tendon to be protective.
Yeah. I'm just looking at the comment. Doreen writes, brachialis fascia restrictions are also fairly frequent in lateral elbow pain. Yes,
Mm-hmm.
for sure. Yes to cervical and thoracic intervention. Get those rings aligned. Doreen and I have taken courses together with LJ Lee and Diane Lee. So I've been on a couple courses with her, and agree with Susan. Wait for things to settle down before addressing the tendinopathy. With eccentric program, when I do start it, often it's with 1 or 2 pounds,
Exactly.
not much. Exactly.
Exactly. Sometimes for me, it's even just, like, do you have a can of, an 8-ounce can?
Yes,
Because
exactly.
it's a nice open grip. I like cans because it's an open grip. So it starts to bring that in, but it's
Mm-hmm.
also light, so what do you have that's lighter? Because, you just have to kind of figure out what they can tolerate and what they can do. I've never been real successful in heavy loading of the tendon early in the
Nope.
lateral elbow.
Nope. Me
I've
neither.
just not, I just haven't. I've tried it a number of times. It hasn't worked for me clinically, which is why I've backed off and thought they need to settle down. We need to figure out kind of where we really, where is, like you like to call it so lovely all the time, where maybe this whole thing set up from. Like, the symptoms are being expressed here, but why?
Right.
Is it because that tissue is in trouble and it was in trouble, or is it because that tissue started to become sensitive and painful because of something else that whole movement system was compensating for?
Yeah. I
And you can do it until you can't, and then when you can't, you become symptomatic, and we got to find another way to do it.
Yeah, and I think by the time they get to us, because there are many people out there who, and myself included, you get elbow pain, you think it's going away, and a month goes by and it's still there, and you're
Mm-hmm.
going to the doctor, and then you're coming, whatever. By the time they get to us, they're at least 3 months, 4 months, sometimes a year.
Already had
Yeah,
injections,
and exactly, and they
Mm-hmm.
haven't. Oh, I'm not doing a bicep curl. I'm fine. Oh, it's just when I lift something. So their tissues, and there's so much congestion in the arm and in the
Mm-hmm.
plexus, the neck, and the thorax, and the shoulder. You cannot. This is my opinion, my humble opinion. You cannot just treat the elbow,
Yeah.
because it won't get better. It will not get better.
Mm-hmm.
So I think it's short term, but the person's going to have to come and come and come and come. So you need to address the congestion in the tissues, whether that's aligning your upper rings, as we call their upper ribs, or
Mm.
working on your neck and doing some distal movement, pain free, or or just adding novel input into the system when appropriate, either in the hands and knees, but just introducing that movement. You need to look, I mean, I've not seen a connection, and I'm sure they exist, but between the foot and the elbow. I've not seen that in my practice. But if someone has elbow pain when they're squatting, and for example, they're lifting weights, I'm looking at their squat and I'm looking at the rest of their chain, but it's mostly with the gripping or with some form of upper extremity movement.
Mm-hmm.
And you need, to progress them through those weight bearing postures
Yeah.
and load the system eventually, because you need to go through the whole program with these people.
Right. And I think what's interesting about that, and what Doreen was talking about too, with the on the hands and knees, or if they can't get on their knees, loaded onto a countertop. And the important thing here is to remember is that when people have painful elbows, and it may not be the elbow joint that's painful, we're talking about soft tissue pain, nerve
Yes.
pain kind of stuff here. It's really not the elbow joint
No.
that's that's gone wrong here, or has gone funky, or whatever, has gotten symptomatic. But what is important here is that when people are hurting, they're gonna, it's almost like if you think about like a dog that has a hurt paw, they're reluctant to put it down.
Yeah.
When we're not talking about the paw pain here, but it's the same with the elbow. I've noticed that people quit, like when they go to even get up out of bed, they won't even push. They have stopped. They don't even like to pull and push doors open.
Yes.
That's that whole piece. That's really, and that's what starts to set in. And then all of a sudden, we have to start thinking about, wow, that tissue now is also being, is the bigger problem for it is now it's being chronically unloaded.
Yes.
Because they're in lack of use, so it's not getting
Mm-hmm.
loaded as much as it should be. And we don't realize how much we use our arms for weight bearing instability, and, and compression and
Yeah.
moving and approximation and all of that stuff. But we have to, we until we kind of like start to look at them. And if we don't put them in these positions, we'll never know. And
No.
I know a lot of people just grab the arm and, start mobilizing the tissue in the, on the lateral elbow and start doing it. I'm kind of more of a show me when and how and why it hurts. It hurts when I push
Mm-hmm.
a door open. Show me.
Well, you think about it, that's the
Show
rate that
me. I need to see it.
exactly.
Yeah.
Yes.
Hmm.
It's
I want to see what they're doing or what they're not doing. It's like, well,
right.
what if you, what
It's
if we like look at this? Maybe you start pushing the door. Does it hurt? Let's figure out a way for you to push that door open so it doesn't hurt, but we can actually start loading.
it's the same as if when you're standing and you have a left foot injury and you're weight bearing on your right leg. So when you have a, let's say, a left elbow injury, you're going to be, your body scheme is going to be biased more towards that right side, because you're going to do everything with your right arm. At least that's what most people tell me. I just don't use it, so I use my right. And so what happens to that left side? It loses its ability to adapt to movement. It can get stiff. It could get underused. It certainly gets underused, but it loses its ability to adapt to movement and load. So
Mm-hmm.
when is an acceptable level of load for these people? Are you going to not, you're not going to start with long lever, bicep curls. You're not going to start with long lever gripping 10-pound weight. That's going to just, flare them up. And I think Doreen wrote a quick comment about I don't know if you could read that.
Yeah, to me, the
About
magic
eccentric.
number is 4. If the patient has an increase in discomfort from the eccentric exercise, it's acceptable as long as it's,
And that's French
yeah,
intensity.
yeah, as long as it is 4 or less on a scale of 1 to 10, that you have some symptoms, but
Yes.
they're not like
Yeah.
spiking, like, really,
Yeah.
neuropathic type symptoms.
Yeah.
If it's more than that, decrease the number of reps or decrease the weight. Absolutely.
I
Scale
agree
it
with
back
that.
down. And some of this is test, retest for sure,
Yeah.
because you don't know until you start.
Mm-hmm.
You don't want to, you want to kind of meet them where they are. And that means you may have to go really low in the beginning. But as you progress, you have to kind of like play with that a little bit and say, okay, have we adapted enough that we can actually increase the reps now and increase the weight bearing, or whatever it is that they're gripping, or whatever it is that the weight that they're gripping, or whatever they're lowering, at
Yeah.
that point. And one of the other things is that I wanted to say with the exercises is that, if this extension, internal rotation, and flexion, I don't know if everybody can see, but this kind of positioning
Mm-hmm.
is the test for it. And why are we not exercising them in that position? So the shoulder
Yep.
extensors, maybe perhaps the triceps, we've got to get some other thing, maybe it's that's where that whole chain comes in.
Right. So you're doing that
Yeah,
this rate.
yep,
Yeah. So you can do
yeah.
like a skull crusher or a,
Hmm. Or maybe
elbow
even just putting their hand in their
hand.
coat or in
Yes.
their shirt, things like that. Those are natural movements, reaching behind and grabbing things. A lot of times
Mm-hmm.
people will reach behind and reach down to grab
Mm-hmm.
something behind them on the floor or whatever. And so I think you looking at those functional movement patterns that go behind the body are really as important as some of the ones that are in front of the body or, above. Like we're kind of used to working more, so maybe even like being able to sit back and weight bear back on the arm.
Mm-hmm. Oh, yes.
Like so you can start, so they can
Yes.
sit back, because I see
And
that
like
a lot with
hook
people in,
lying. You mean like a hook
yeah,
line
like
to find?
hook
Yeah.
lined, they can sit back or they can just long sit back or they can sit in a chair and come back, just kind of like if you reach behind you and it hurts, show me. Let me see what it is and let's
Yes.
figure it out. Show me how you're getting in and out of bed.
Yeah. And that
You
usually
know,
hurts.
yeah, and because they're completely not using their arm,
Yeah. Yeah.
because it hurts. So it's
Yeah.
like, well, let's figure this out. Let's figure out which piece you're not doing and let's start beginning to load that and start getting that in there again.
Yeah, you could also take like, and even just take your arm and do like shoulder, internal. I mean, just really sort of tension
Mm-hmm.
this on my left arm here, and just do some internal, external rotation with the band and getting as far back. I'm a bit stiff, but a bit as far back as you can, and even going down like that as
Mm-hmm.
well, like you mentioned earlier. I think those are great ideas, going
Mm-hmm.
behind the body, because that's what really helps. So if you think about the weight bearing, you could go on your elbows. You could probably, I'm just thinking of anything else you could possibly do from, because you could do a down dog, but that's definitely in front. You could probably do some things, facing away from the wall, having your hands behind the wall, almost like you're stretching your pecs out, which is doing some, taking a TheraBand behind you. I'm facing away from the wall. My hands are behind me, and just doing some things with bands behind you as well,
Mm-hmm.
just to give them, because some people want exercises so you can trick their system and putting them in a position like, behind your body, but doing something with the band or weights, just to think that,
Yeah.
get them the sense that they're doing something.
Mm-hmm. And a lot of
I do
people,
like that.
yeah, a lot of people have trouble putting their coats on or their jackets on or their shirts on if you're living in the South right now, or
Yeah.
whatever.
Above
They
your
have
head.
trouble reaching behind them or, doing those types of activities. So that's also a good way to kind of think about, how function, and functional activities can drive your treatment program just a bit more.
Yeah.
So
Any other questions or any
I don't
other?
think so. Thanks for listening,
Okay, this
everybody.
was good. I like this. We don't
This was,
see, yeah,
mm-hmm.
elbow. Yeah, I'm sorry, Susan. I just say,
That's all right. We're
elbow's been, sort
We'll
of
be
an issue.
talking about this on a podcast soon.
Yeah.
Um,
Yeah.
so, because I've had a few of these come up, and I thought, it's a good time to kind of start introducing the subject and seeing what other people think. Thank you, Annie, for
Thank you,
watching,
Maddie.
and
Thanks, everybody.
yep,
Thanks,
and
Doreen.
Annette
Thank
and
you.
Doreen, and yeah, leave your comments if you're seeing this a little bit later. Let us know what you
Yeah,
think.
would love to hear your thoughts.
Have a great
Yeah,
Thursday,
absolutely.
and
I
hopefully we'll see
enjoyed.
you next week.
Sounds good. Bye, everybody.